Jessica is an eye health coordinator for Aboriginal Health Council of WA, and Jess will engage us in a discussion on integrating and coordinating culturally appropriate care for Indigenous patients and families along the eye health pathway. This will be an opportunity for us to identify and discuss cultural protocols, clinical governance, and strategies for integrating health services within Aboriginal community-controlled health services. So if you could please join me in welcoming Jess.
Thank you, Kaiba. And thanks, Losse, for delivering that presentation for us. It's always a pleasure. And as someone who actually went to the last conference, it was amazing. And thanks, Mitchell, for your team as well and what you did. We had the pleasure of going to Luchawita, which is very beautiful. I've never been there myself, and it was an absolute pleasure to meet those in the eye space, to learn about the Aboriginal culture down there, and how resilient the mob are from what happened down there and where they've come to and how strong they are. So just to start, my name is Jess. I'm a Yamaji Yorga. I was born and raised in my father's country, Nugajabana, in the midwest of WA. My mother is a Martu Yorga. Her mob are from the Western Desert region. They live in and around the Gascoyne and Pilbara of WA. There we go. My apologies. This is the first time I'm doing a presentation, so if I start to talk too fast, please someone just maybe just go like this, because I do tend to speak very fast when I get very nervous. So as a Yamaji woman living, working and raising my family here in beautiful Perth, I wish to acknowledge the Whadjuk people of the Noongar Nation. I acknowledge their rich traditional culture, and thank them for their ongoing contributions in the field of health. So just a little bit about me. I'm the Eye Health Program Coordinator. I work with the Aboriginal Health Council of WA. We are the peak body for Aboriginal health. My primary role within the organisation is to provide education to Aboriginal healthcare workers, practitioners and nurses in the eye space. So as we saw through some of Losse's presentation, education is a huge gap amongst our Aboriginal health practitioners at the moment around the eye space. And my role came about to fill that gap. So I do education around chronic illness and how it affects eye health. We also provide education on using the retinal scanners, and I believe a few of our workers from around the regions are here at the moment. So obviously we have 23 member services throughout WA, right from the top of the Kimberleys right down to the southwest. So my role is huge. I'm also a registered nurse by trade, and I specialise, prior to coming into this role, my specialty was in rural and remote emergency care, and I've worked everywhere from the Pilbara right down to southwest WA, and everywhere in between. And I initially started my training at Alice Springs Hospital in their emergency department there, so I've had the opportunity to move around a bit as part of my role. The disparities in Aboriginal health outcomes compared to those of non-Aboriginal people is very well known, not just here in Australia, but Indigenous people all over the world. There is a multitude of complex factors that drive Aboriginal health inequalities, including a violent colonial history that resulted in the slaughter of the Indigenous population, the appropriation of Indigenous wealth and land, which has led to Aboriginal people now having detrimental exposures to the determinants of health, and poor access to health services and suboptimal quality of care. Historically, the Australian health system has not provided safe and high quality care to meet the needs of Aboriginal people. The health system in the past included segregated wards, deliberate substandard care, forced removal of newborn babies from mothers who were considered not competent and not able to provide the right upbringing, and the removal of children from the home while parents were sick in hospital, and the failure to return those children to their parents' care. Healthcare institutions still carry this fear for many Aboriginal people. when I was writing this particular slide, it actually didn't occur to me how prevalent this issue still is. When I think about my mum, she's had many health concerns over the last few years, and she has had to have a number of operations. She goes into hospital, she has her procedures. And as a nurse, and I've been a nurse now for a decade, I didn't understand the need and the rush for her to want to leave hospital, sometimes within 24 hours of having her surgery. I didn't understand. And as I was writing this, everything just kind of fell into place, because for my mum's generation, that fear is still there. Her mum was part of the stolen generation, and they would tell stories about how Native Welfare used to knock on the door to try and take my mum and her brothers and sisters away. So having to rush to the hospital within hours of my mum, or my mum saying, don't leave, just wait for me to get out. And as soon as she was awake and alert, she said, let's go, even though she still had care that was still required of her in hospital. So even though we talk about the past, it actually is still quite prevalent now. So how do we provide a safe space for someone like my mum, who has this huge fear of hospitals, to actually remain there to receive the care that is required of her? So addressing health inequalities in Aboriginal people requires addressing social and cultural determinants of health. The social determinants of health look at the non-medical factors that influence one's health outcomes. They are the conditions in which people grow, are born, work, live and age, and the wider set of forces and systems shaping the conditions of daily life, including economic policies, systems, social norms, policies and political systems. As well as acknowledging the social determinants of health, those working in the health field, particularly with Aboriginal people, also need to understand the cultural determinants of health, and that also affect Aboriginal health outcomes. Understanding the link between family, country, cultural identity and self-determination, and how it impacts on the overall health and well-being of Aboriginal people, is vital when providing care. So when we're looking at models of care, when we're looking at frameworks, I came across this study which actually reviewed a multitude of studies that were looking specifically at cultural determinants of health. So the social determinants of health are very, very important, but we also need to understand the link of the cultural aspects, particularly for Aboriginal people. We need to understand connections to land. We need to understand connections to family. We need to understand the connection to obligations. And I always say to people, particularly when I'm going out providing eye training, sometimes, believe it or not, attending sorry business is more important than attending the clinic to have an eye scan. It just is. What we need to do as clinicians is, when our patients come back to the clinics, is not make them feel bad about that, and acknowledge that they were attending a cultural ceremony, or their family is more important, or there is something going on and that is more important, and then just do those checks at the time. Point of contact care is really important. So again, part of my role is, if your optometrist is only coming once a month or once every second month, how do we capture those patients in the interim? And what we need to do is make sure we're providing that education to our Aboriginal health workers and practitioners who are at that clinic every single day to provide the care that's required for our patients in a culturally safe way. Health professionals and healthcare organisations are important contributors to inequality in healthcare experienced by Aboriginal people. The therapeutic relationship between a healthcare provider and the patient is especially vulnerable to the influence of bias, whether intentional or unintentional. Identifying one's biases can be a confronting experience, but in order to provide culturally safe care to Aboriginal people, it is important. Becoming a culturally competent clinician is about you as an individual learning to understand and respect the values, beliefs, attitudes and culture of others. Once we're able to really understand these differences, we are then able to coordinate the care of our patients more effectively. Cultural safety needs to be addressed from a systemic level. A study in 2023 defined cultural safety as a decolonising, transformative and participatory approach aimed at achieving healthcare that recognises, respects and nurtures the unique needs, rights and cultural identity of Aboriginal peoples. Cultural safety is about shifting the focus from the interaction between the patient and the healthcare clinician to the understanding of health and of power inequalities underlying the health system. So when we talk about it from an individual level, we're talking about cultural awareness. We're talking about cultural competency. It's about you as an individual learning how to respect and acknowledge other cultures. When we talk about cultural safety, we're talking about it from a systemic level. We're talking about it from an organisational level. What can an organisation do to make your clinic, your hospital, your optometry clinic safer for an Aboriginal person to walk into? If your service is not providing a culturally safe space for Aboriginal people will not attend your service. I was recently speaking to an Aboriginal health worker who works in one of our clinics here in Perth, and their retinal scanner is damaged at the moment. They've had it repaired, but it broke again in a power surge. And so they were trying to work with a local optometrist in the shopping centre just next door for their Aboriginal patients to go to have just retinal scanning. And patients are refusing to go because when they walk into that optometrist, it's not a safe space for them. So we're already missing basic eye care for our patients because our clinics aren't able to provide that service currently. So we need to start from a systemic level and provide that safe space for Aboriginal people when that option's not available for them in their normal clinics. So some examples of how organisations can achieve cultural safety for patients and clients include changing policies to adequately address the circumstances of diverse communities, including Aboriginal stakeholders in the decision-making process and in the conversation. You can't make cultural safe changes in your clinic if you're not including Aboriginal people in the discussion. Having a diverse workforce, so including Aboriginal workers in your organisation, and supporting your workforce to attend cultural competency training and engaging with Aboriginal people. A culturally safe workforce considers power relations, cultural differences and the rights of the patient, and encourages workers to reflect on their own attitudes and beliefs. Cultural safety is achieved when individuals feel safe and cultural differences are respected. And that's it from me. So does anyone have any questions? Or does anyone have any thoughts, particularly in their clinics, if you work, particularly if you do work in an ACCHS, of how you are into incorporating cultural safety in your organisation? Yep. Yep. Oh, we'll give you a mic if that's okay. Deep breath. I've been doing it all morning.
Hi, I'm Roberta. I work in the wheat belt, but the closest optometrist service that comes to us, so I'm from Narrogin, but they come from Bunbury, and that's like an hour and a bit away, and it's really inaccessible to some of our clients, and they maybe come to Narrogin maybe a couple times, like once every couple of months, but sometimes when the clients go there, they don't feel very like it's very culturally appropriate for them, and it's not really a safe space. So I feel like what you're saying is if we could get more cultural awareness to that site, maybe we can get more our clients getting like more safe practices from them. Yeah.
100%.
Yeah, it's just like what you're saying was really relevant to our workplace, and it's really hard for them to get to Bunbury for really important eye surgeries that could take an hour or so, but sometimes the people that work there, they don't understand that we have to come from hours away just to see them for a 1 hour session or to talk to them for half an hour. So yeah, what I'm saying is it'd be good to get more education to all these optometrist places and stuff.
Yeah, so part of what you're saying I hear all the time. So part of the visiting optometrists that come out to the services, sometimes they all come from the same place, sometimes they come from private optometrists. It depends on what the agreement is that you have with your organisation. So first and foremost, finding out where they're coming from and then being able to feed that information back. So what I would probably suggest is making contact. You're literally in a room full of allies here. You're in a room full of people who are really passionate about Aboriginal health and Aboriginal eye health specifically. So being able to feed back to your visiting optometrist that they're not actually practicing in a culturally safe way and actually feeling safe to be able to do that is something that we need to be able to help develop and discuss with you and see where we can go from there. So, yeah. And yeah, you're right. Bunbury's a long way away. And yeah, if they're only coming once a week and patients are realising that it's not a safe space, then they just won't go at all. So.
And especially if, when you say sorry business is going on or something very much more important in their lives, and you know, us blackfellas, anything could happen on the day, so we're not going to say, we could say yes, we're coming to the appointment, but then something could happen, but I don't think some clinics understand that about Aboriginal people, that family's more important and that anything could happen on the day. So
that's right.
And then some of the clinics, they get angry about clients not attending, even though we have something more important in our lives going on.
And I know you're sitting at the front here and I can see beyond you and all I'm seeing is this because people get it and they understand. So yeah, we do need to do better in that space, and those that do work in these higher organisations, particularly those that maybe aren't working in an ACCHS and you're partially responsible for sending your optometrists out, I hope you're listening, because this is where you as heads of these organisations have a responsibility to make sure that the staff that you're sending out are practising in a culturally safe way.
Thank you.
Roberta.
I might come see you later. Have
For
a
sure.
proper yarn.
So at the moment, and Gary will, I was just having a talk to him about it, and some of my manager. Currently my funding, I only provide training to our member services. So if you are, I've been to quite a few. However, if I'm able to come down, if you've got a member service in your area, I can actually invite you into that service to do training with our Aboriginal health workers and practitioners. However, we are currently coming up with a plan of how we can deliver more training outside of our ACCHS. So my contact details are there. Please email us and we'll have that discussion with you. So.
Hi, Jess.
Oh, sorry, I've got.
Hi, Jess. Deadly speak.
Thank you.
You hit the nail on the head with so many things, and to think that people like your mum are still experiencing those type of feelings when she is a patient, and it probably only happened, not so long ago. You talk about the importance of learning and practicing differently and in a culturally safe and appropriate way. For me, my question really is about, this is so important because it will make or break whether or not our mob will actually come to an appointment. And the young lady, she hit the nail on the head. Like I always say to people, don't have a clinic on a Friday. Most of our mob will have funerals on Friday.
Yeah.
So, they weigh it up, as the young lady said, is that funeral on Friday, I appointment. Nah, I'll make another appointment. I can't make, or there will not be another opportunity to go pay respect. I suppose my question, it's not really a question, is to say to places like UWA, well, how much of the students' learning is around cultural awareness? is around all that, and not just learning it, but actually participating in it and actually feeling it and hearing it and being a part of the delivery of it. Because it's one thing where people can go to a cultural awareness session, tick a box, it's done. But it's actually seeing it working in that space where you'll actually know then that it's actually been taken on board. And I know UWA is sitting behind me here, and and Graham's. I'm the CEO of the Jordan Aboriginal Medical Service, and my deadly team here is Mr. D or Mr. D. I've been trying to get him to be Mr. D, like our Mary G is,
Obviously.
but he's not into that. And then of course Maggie Peel, who's my clinical services director, but also our partners in UWA and with Wolfred. We've had an amazing journey, and we're doing a presentation. But for me, it is so critical that this cultural component of service delivery and management, development and implementation and evaluation, it has got to be embedded. Otherwise, we will continue to have mob not, turning up for services, mob walking out of hospital, because in the eyes of the health system, if our mob get up and go or they don't turn up, there's a dirty big red mark against our name.
Absolutely.
But in actual fact, there are strong reasons why, cultural reasons why our mob are actually not, participating in it.
Yeah, and I think, Debbie, that's a really important point. I do, at the end of my presentation, I just said, when we are encouraging or providing cultural competency training to our staff members, one of the statements I also said was making sure that you're also spending time with Aboriginal people. We all know, and it doesn't matter if, like me as an Aboriginal person and I go overseas, visiting a new country and learning a new culture can be really confronting. But that confrontation goes away the more time you spend with those people, with that culture, and learning just the beauty behind what makes those people those people. So along with cultural competency training, which is a tick box, maybe what we also need to do is making sure that we're sending people out to services, which I know Gary is trying very hard to do, and just getting his students out into the ACCHS sector to expose students to working with beautiful Aboriginal people, with our mob. Our mob is solid.
My name's Peter Tidman, and my mum was the first Amerindian. She was out of the jungles that went to, she had an eidetic memory. So she got trained in England as an optometrist and was mentored by Professor Ida Mann when she came here in the 60s. She would tell us about her granddad who went out to places in the jungle where they had a disease, and sometimes when they'd come back, the family would burn all their clothes. And she gave me stories, and my dad, when they came out here in the 60s, he wanted to be a jackaroo. And so they both instilled in me that once I finished my optometry, that I'd go up into the northwest, which is what I did. And I worked with Peter Graham, who was the ophthalmologist up there, and we did a lot of work with the trachoma. One of the things that you got to also realise is that people that have suffered from trachoma as they get older, it affects your eyelids, and more often than not, they get interned eyelashes. And so that mob, they won't say anything to you until I look at them and I say, your eyes are watering, and they say, oh, the doctor's given me this drop and that drop, and they think that's it. And then I look in with the required slit lamp and I pull out one hair and they hug me. In terms of a culturally safe place, when I came down here, I spent 20 years with Bunjima mob, with IBN and Gumala and different mobs. And when I would go into a place like Bindi Bindi village, I would first go down to the village because nobody was coming up to the hospital. And I'd play my guitar. And they used to think, well, if he's going to play his guitar, we'll go up and see him. But we used to see him outside the hospital, because anybody who goes to the hospital can die. So you don't go to the hospital. So when I came down here, I joined up with Derbyl Yerrigan, and they had a really good program with the bush bee mob, I call them. She was, or sometimes I used to call her big girl, but anyway, just very quietly. We would go with as an eye team, with the ear health and the physio, who was trained in meditative techniques. And we'd go to the schools, and as one big family mob, we'd put on a lunch, a safe lunch, a diabetic, for a good lunch. And we'd invite all the families to be in the room with us. I would have all the families in the room with us as I would test somebody. And so they would come in, and I had a lot of connection up north, and so we'd more often than not talk about families, and then all the eye bit was done, and then I'd ask them about their ears and whatnot. And I really liked that model, because we're in a big room like this, no closed in spaces, 3x3 boxy little rooms with a whole stack of frames outside. But a big room, lots of chairs, lots of food. And I'd sit down there in the middle of it, and you'd have children coming up and playing with your eye little bits. And so I had an extra one that they could come and just play with them, because if you don't do that, it's all scary stuff. And more often than not, I would show them how to use an ophthalmoscope. And there's some tricks that you can do that makes people really comfortable. You can see, and I won't go into that, but I would do all these tricks. Anyway, that was I really liked that model. I was a bit burnt out from being up north, because I was involved in a lot of corporations and the management of those corporations. But that program that went out to the southwest, I loved it. And there was a mob of us that would go up. We'd move as family. We'd be there as family, and then come back and,
Yeah, that's
think about it.
a beautiful story. It's a lovely wraparound service that you can provide as well. So you're not just doing eyes, you're doing lots of care all at the same time, and involving the family, which is what's going to make your children feel comfortable, but also your elders feel comfortable. So to be able to incorporate those sort of services out there, 100%. Anyone else? Thank you.